So, Stephanie, sorry. So this one is shorter because the intravenous one, I mean, a lot of it has been shown with Andrej and Stephanie and Rich. So we do the same things for children. I just want to emphasize a few points only. So the same center, the same grants, and I want to thank all these people. And I just want to briefly, specifically address the pediatric IV contrast safety, the technique, and give you a few case examples. So there are a number of studies that have evaluated contrast safety, intravenous contrast safety in children. There are not as many as the reflux, because the reflux studies were much more earlier and much more widespread than the IV one. And just simply the indications, the numbers, just compared to adults are fewer. But still, there are sufficient studies. This was a systematic review of Sonoview and Optizone with over 500 children, and 1 severe adverse events and 9 minor ones. And in this one, the 11-year-old had an anaphylactic reaction, and there was targeted focused treatment, and the patient did well. So we have allergic reactions, anaphylactic reactions. The one practice change we need to do in our ultrasound unit is we now have a code card in the ultrasound unit, which we didn't have before. We never had in the department any anaphylactic reactions, but we do have a code card just in case. And the 9 were self-limited, like headache, altered test, nausea, tinnitus, and light-headedness. 3 had follow-up intravenous contrast, and the reaction did not occur. In another group, the adverse events were mild ones, and one was severe with flushing and emesis, and this one patient was also treated with fluid antihistamine. So over 1,000 children, over 1,000 exam, 2 severe adverse events, 11 minor adverse events. So really a high safety profile. And the rate of anaphylactic reaction is much less compared to MR and CT and X-ray contrast agents. So overall, very safe, but a new method. So somewhere nearby, it's good to have a code card, but it's the chances that you'll have anaphylactic reaction is very rare. How do we do it? The way we reconstitute and inject using a 3-way stopcock is similar to what has been previously described. Very important to inject it directly and not from the side opening. And this I want to show you. And so if you see the first image, this was a patient I did on a bedside in the ICU. We were doing a renal contrast ultrasound, and I asked the nurse to inject it. She injected, and then there was no contrast, or it was very little. And I realized she injected from 90 degree. And the same patient, right after that, we injected directly at 180 degree, and this is what happened. So this was from the side, and the other one was directly 180 degree. This is something just to be aware of in practice. It may mess up your exam, so make sure you inject it directly. That is very important. And we collaborated with the Jefferson group and did some in vitro studies, and we found out that how if you inject, the red is the perpendicular from the side, and then the black one is the straight, that with injection from the side, you really reduce the enhancement. And this has been really nicely shown in vitro testing. This is what happens if you do the perpendicular. That's for Optizone and Lumason. Interestingly, Lumason is slightly less affected than Optizone. And the other thing is the connectors. You know, in our institution, because of CLABSI, they use a lot of connectors to avoid and reduce the infection rate. And these are the connectors. This is the way they look inside. And if you use these connectors also, So the dotted black lines are the connectors. There is some decrease of contrast enhancement, but it's not as much as the injection from the side port. But it's important to remember that this can make a difference. So what we agreed in our institution is for peripheral lines, we remove the connectors. And the nurses are happy, and everyone is happy, and we place new connectors after we finish. For central lines, where we use also, we do not remove the connectors, just to reduce the chance of infection. But then what we do is we increase the dose of contrast to compensate for the loss of the microbubbles. So this is what happens. So all these things can have effect on the contrast enhancement. The dose that is, again, in the FDA approval is 0.03 ml per kilogram up to a maximum of 2.4, and we can give up to 4.8. But there are different dose recommendations in the literature. And now we have the scanners, which are becoming much more sensitive, and even these doses appear to be way too high. But I think it's a good starting point what the FDA put in the recommendation, 0.03 ml per kilogram, and then go down from that dose. It is less frequent that you need to give more dose than lower dose. The only times when you might have need for more dose is when you use linear transducers at high frequency linear transducers. You may need to increase the dose. And also when you examine small organs like the testes, then you might need to have higher dose. But otherwise, starting with a 0.03 and going from that is important. And all these factors do affect the contrast dose in our patients. So we start with a grayscale and Doppler. We look at the focal lesions, and then we do a screening exam for trauma, infections, or additional lesions. Here is a patient, a 1-month-old boy, at a bedside examination of a liver lesion incidentally found during evaluation for vomiting and hypertrophic pyloric stenosis. You see this hypoechoic primarily with some echogenic area, focal lesion, which is hyperemic. On the contrast administration, you see that it enhances from the periphery to the center, very nicely demonstrated here. Look again, enhancing from the periphery to the center, but not completely filling out. It was an infantile hemangioma in this case. In a retrospective study, the group from King's College had over 300 patients with 147 focal lesions. And very important to note that in 50% of patients, once they did the contrast ultrasound, they did not need any more CT or MR. And this has already been described nicely by Stephanie. Depending on the pattern of filling of the focal lesions, we have these images. We can make the different diagnoses based on the arterial, portal venous, and late venous flow. Trauma is one of the other important indications that we look at. We scan the right side, the kidney and the liver, and then move over to the left side to scan the left kidney and the spleen. Homogeneous enhancement is normal. If there is any disruption of enhancement or any dark area, that's a lesion. This is just to show you the left kidney and the spleen. And then we look also at the pancreas. In the middle, you see weight and then starting enhancing now and significantly enhancing. So that's sort of the standard where we look at the different organs. In this patient, a 7-year-old girl who presents after 3 days after fall, you see some increased echogenicity in this area of the liver. And when you do contrast ultrasound, you see much more dark area, and that's the lesion, the traumatic lesion of the liver throughout in the right lobe. You see it very nicely on the contrast ultrasound. There are a few studies that have shown that contrast ultrasound in pediatric blunt abdominal trauma is useful. The first study, they had 14 injuries in 12 children, and only one lesion was missed. It was an adrenal lesion where there was a splenic lesion. The second one was 67 injuries in 73 children. All were detected, and this is a smaller study with 21 injuries in 18 patients. And they missed these lesions. However, this was a limited study where the dose of contrast was not only low, but they had only limited number of possibilities of injecting and evaluation. So for stable blunt abdominal trauma, you can use also the scoring according to the American Association for Surgery of Trauma. One thing issue is that you are not able to see the collecting system, so it's not excreted. You will not have visualization of injury to the ureter using this. Just a few case examples. Here, an 11-year-old girl fall 15 feet out of a tree. Very hard to see anything on the grayscale, but on the contrast ultrasound, you see the areas of the splenic laceration very nicely. And this was a boy who was kneed in the abdomen during baseball game, and CT was done. You see the fracture of the kidney on the right with perirenal hematoma. This was a shattered kidney. And 2 days later, his hemoglobin fell from 11 to 8, and then the clinicians were inquiring whether he's still bleeding. And this was the grayscale imaging demonstrating the perirenal hematoma. The kidney has a heterogeneous echo texture. It's hard to see, but the contrast ultrasound, if you look at the circle, you'd be gradually seeing there is a lot of area which is not enhanced, which is dark. The upper pole is enhanced. Some part of the lower pole is enhanced. But if you look carefully, there is extravasation of the contrast in the perirenal space. You see it's flushing up. So you can see the extravasation really nicely with the contrast ultrasound. There was active bleeding during the examination, which explains the hemoglobin drop. And 1 month after that, the follow-up showed a better perfusion of the kidney. In the liver, this is a 4-year-old girl with complex medical history and liver nodules. You see the nodule, the focal lesion enhancing and filling up and not washing out. This is the single images from the central to the periphery, and this was an FNH, and you've seen a number of examples. Another girl with incidental liver lesion seen on the MR. The follow-up we did with ultrasound, that was actually a pelvic MR, so the liver was just partially depicted there. You see this hypoechoic lesion. And on contrast administration, you see how it fills up. And then, if you look carefully later on, it washes out early. And this was a case of hepatoblastoma. This 19-year-old with relapsed Ewing sarcoma came with this focal lesion in the liver. You see how it enhances at 20 seconds, 60 seconds, and 1 minute and 20 it washes out, and it was a metastasis. Just to demonstrate to you how useful it was also in children in the liver. For indeterminate renal lesions, Rich is really the expert. We're trying to copy Rich and do the same thing he has done for adults for children to classify all the lesions accordingly, and this is what we use now. He has changed the indeterminate one. He says most of them are benign, so we're following this classification. And here you see a 16-year-old boy, back pain and urinary incontinence, multicystic lesion, on contrast ultrasound, on contrast On CT, this is how it looks like. You don't see the septations on CT, but on ultrasound, you see thick septations, actually, multiples, and they are contrasted, all these septations. So they are a little bit worse than the thin septations in this one, so they make you a little bit worried. It was a cystic nephroma on histology. This is an interesting case, a patient with actually a bladder extrophy with an incidental finding of an echogenic lesion in the kidney. This is a solid echogenic lesion, and not much color flow is seen, but on contrast ultrasound, you see the whole thing is enhancing, and if you wait a little, you may see that it is washing out early, and it was a renal cell carcinoma. And that's what also Stephanie mentioned. If you have washout, you worry. And those with washout, we really say, okay, let's do biopsies. I mean, we don't even have that many number of cases like in adults, so we do that. So for pyelonephritis, it's very helpful to detect that, and Rich has mentioned that. And this is a case, it's seen on CT, pyelonephritis on grayscale, very hard to see even on power Doppler, but on contrast ultrasound, you see these area of absence of contrast. These are the affected areas, especially in the lower pole, and 2 weeks follow-up demonstrates that there is an improvement because now there is a homogeneous enhancement up to the periphery and only small areas where there is some lack of enhancement. And 6 months later, you know, that affected area indeed demonstrates significant scarring. So in summary, contrast ultrasound, even intravenous in children, is safe. We showed you the technique, which is similar to the adult, and hope to demonstrate with few examples its utility. Any questions? Thank you very much. Any? Yes, please. Yeah. Yes. 15%. 15% don't void on the table. So if they don't void, the only thing, there are especially 2-3-year-olds who just learned to be potty trained, they can't understand why you want them to void on the table. So it's very hard. Sometimes, so we've done studies, 15% you won't get to void. So if you don't get them to void, the next thing you do is you ask them to go to the restroom and void, and significant number void on the restroom, but still there are very few, and then you scan them right away after that. But in your report, you have to say, during voiding, I didn't see reflux. That doesn't, it's nothing different than from VCUG, that's the same thing. And those that absolutely do not void, yeah, you will have a few that will not, then you have to mention that the urethra is not evaluated, the patient did not void. 20% of reflux happens during voiding. So you may be missing in these children. Any other question? So the 0.03 ml per kilogram, that's the common one. Yeah, so 0.03 ml per kilogram. That's the easiest one. So if I give you one dose, then you go to this machine, that's already too much. The next one, it may be less. So I give you this as a starting, knowing the tendency with the newer machines that you might need to give less. And when you use high frequency, you need to give more.
When I go into presenter view, I don't get the whole thing to come up on the